بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are continuing the series of female pelvic imaging, and we have finished with the anatomy and the techniques, and also we have finished with the uterine pathology. And now we are going to discuss the ovarian lesions, and this will be handled on two lectures. The first one will deal with some of the benign ovarian pathology, and the second one will deal with the malignant ovarian lesions, fallopian tube pathology, and finally the vaginal pathology. Then these are the topics we'd like to handle in these coming two lectures: the anatomy and techniques, ovarian cysts, benign ovarian neoplasms, malignancies, fallopian tube pathology, pelvic congestion syndrome, and finally the vaginal pathology. The ovarian cysts are too many, and we are going to discuss the functional cysts, the simple ovarian cysts, the corpus luteum cysts, para-ovarian cysts, hemorrhagic, and endometriotic cysts, thick lutein cysts, and polycystic ovary syndrome. And you know that the ovary have cyclic changes, and you know that the follicles start to mature until the development of the Graafian follicle, which will ovulate and degenerate into the corpus luteum and finally into the corpus albicans. That's to say, each ovary during any time of the menstrual cycle will contain a number of follicles which will appear as cystic fluid filled structures within the ovary itself. And this is the usual appearance of the ovary by transvaginal ultrasound. You see some of the follicles appearing as cystic hypoechoic structures, usually arranged on the periphery of the ovary, and they are usually of different sizes. Then the regular size of the ovary is about 3 to 5 centimeter in length, 1.5 to 3 centimeter in width, and about 1 centimeter in thickness. The CT is the least sensitive in the imaging modalities compared to ultrasound and MRI in evaluation or in the detection of the normal ovaries. And this is an example. This is the left ovary and this is the right ovary. And you may need to, of course, opacify the bowel by oral contrast media. And many times you need to inject the contrast material so that you will be able to see the normal ovaries. But the transvaginal ultrasound is a good modality for evaluation of the ovaries and also MRI. The ovaries are identified better in the T2 weighted image by the detection of these cystic hyperintense follicles within the ovary, and usually it is difficult to see the ovary in the T1 weighted image, but it is easy in the T2 weighted image guided by the ovarian follicles. And this is the normal appearance of the ovary in T2 weighted image, and this is another appearance, and you see multiple variable sized cystic lesions within the ovary, as you can see in this T2 weighted images. And normal ovaries will contain a number of follicles or functional ovarian cysts, and these cysts are usually of different sizes. And the largest one is known as the leading follicle, which will after some time will ovulate, and the rest of the cysts will degenerate and the new cysts will appear. This is the appearance of the normal ovary by CT scan on the right side. And the corpus luteum cyst is the sequelae of ovulation, and this cyst usually represents the leading follicle after ovulation. It usually contains some blood, and that's why it will appear of bright signal in the T1 and T2 weighted images. This corpus luteum cyst may persist for 2 or 3 menstrual cycles, and this cyst may produce progesterone, resulting in delayed menstruation or bleeding abnormalities. And this is just an example by MRI T2 and T1 fat suppressed images. And you see this is the corpus luteum cyst. These are the Graafian follicles. And the cyst appears to some extent of high signal in the T1 and T2 weighted image, denoting the presence of blood elements. And this is another example of corpus luteum cyst. And in the coronal T1 and T2, and in T1 post contrast, you see the cyst with some faint high signal rim inside, representing the blood products. And in the post contrast study, you can see some marginal enhancement. Then many times you are able to see also some of the fibroids within the uterus. And considering congenital ovarian anomalies, most of these anomalies are extremely rare. Considering unilateral agenesis of the ovary or supernumerary ovary, and the congenital abnormalities of the fallopian tube are also extremely rare. Then what about the physiologic ovarian cyst or the functional ovarian cyst, which means that the one of the cysts that will grow to ovulate later on, and this functional cyst do not usually exceed the size of 5 centimeter. It is usually in the range of 2 to 3 centimeter, but some of the functional cysts may grow up to 10 centimeters, and these cysts will regress spontaneously, and they may require 2 or 3 months to reach the full regression. And simple ovarian cyst is like a cyst anywhere in the body. It has 7 criteria, and these criteria are 3 positive and 4 negative criteria. Number one is a sharply defined margin, paper thin wall, clear water content, and there is no internal septation, mural calcification, enhancement, or mural nodules. And this is an example of a simple ovarian cyst showing clear water density, paper thin wall, sharp, well-defined margin, and clear water content. Then whenever you are able to see the ovaries, and there is a simple cyst which is separate from the ovaries, and you can call this a ovarian cyst. And this is a well-known lesion in the clinical practice, and it should not be mistaken for any other pathology. I can show one of these lesions. This is the left ovary and this is the right ovary by CT, and there is a big cyst in the pelvis, and this is a para-ovarian cyst. Then a para-ovarian cyst may be mistaken for ovarian cyst adenoma, or what's known as eccentric ovarian cyst or retroperitoneal cyst or hydrosalpinx. But you know, the tubal appearance of the dilated fallopian tube can be easily differentiated from these para-ovarian cysts, as I will show to you. And some of the ovarian cysts contain hemorrhage, and this will appear on the MRI and T1 weighted images of bright signal, and also on T2 weighted images of bright signal. Hemorrhage is a well-known finding in corpus luteum cyst, and it also may occur in the functional cysts. Then the hemorrhagic cyst, if it is larger than 5 centimeter in diameter in the premenopausal woman, you should follow this cyst by ultrasound or by, um, it's better by ultrasound. And the cyst of any size that is hemorrhagic in the post-menopausal woman should be followed up, and cyst in the late menopausal patient, which is hemorrhagic, should be surgically removed. Then if you look to the MRI T1 weighted image and you see this margin of right signal which represents blood, and then the T2 weighted image, the margin is relatively darker, and this means that you are dealing with early subacute blood, or what we call intracellular methemoglobin. And whenever you are confronted by a cyst which is of high signal in the T1 weighted image, and you should have some of the sequences which is suppress fat in order to be sure that you are looking at is not fat but blood. And this is an example here, the cyst in the T1 and T2 weighted image, and in the stir image or any of the fat suppressed images, you see that the cyst is not suppressed, meaning that it contains blood. Then one of the hemorrhagic cysts occurring in the ovary is the ovarian endometriosis or the chocolate cyst or the endometriotic cyst. And this cyst will appear due to the presence of ectopic endometrium within the ovary, and the cyst is usually small in the range of 2 to 5 centimeter but may reach up to 20 centimeter in size. The cyst contains degenerated blood flowing following repeated cyclic hemorrhage. And you know that ectopic endometrium and occur in all these areas, and the ectopic endometrium in the myometrium is known as adenomyosis, and this is the only endometrium which does not show cyclic changes, but endometriosis can commonly occur in the ovaries, in the broad ligament, anterior cul-de-sac, posterior cul-de-sac, ureterosacral ligament, the tubes, the colon, and the ureter. And frequently, the endometriotic cyst will appear like this by MRI, by ultrasound. This is the simple cyst, which is hypoechoic with posterior acoustic shadowing. But the endometriotic cyst containing blood will appear with internal echoes, as you can see, with no posterior acoustic enhancement. And one of the criteria for endometriotic cyst to differentiate it from a hemorrhagic ovarian cyst is what's known as the shading sign. And the shading sign means that in the T2 weighted image, the cyst will lose its brightness and the T2 weighted image compared to the hemorrhagic cyst. Hemorrhagic cyst will appear bright in the T1 and bright in the T2, but the endometriotic cyst will appear bright in the T1 but less bright in the T2. And this is an example. This is a T1 weighted image. You see the hemorrhage, and you see in the T2 weighted image some decrease of the signal, and this is what we call the shading sign. Also, one of the signs that can help you to suspect the possibility of an endometrioma is the presence, the concomitant presence of uterine adenomyosis. And this is very thickened to myometrium with loss of the definition of the junction zone, as I have mentioned before. And this is diagnostic of adenomyosis, and this is an endometrioma in the ovary. Then look at these images. This is T1, T2, and T1 fat suppress image. In the T1, the cyst is bright, containing internal septation, and there is drop of the signal in the T2 weighted image, and this is known as the shading sign. While with fat suppressed images, the lesion is not suppressed, meaning that it contains blood, not fat. Then ovarian endometriosis can be easily discriminated from a hemorrhagic ovarian cyst. by the drop-off signal in the T2 weighted image or by the shading sign. From ovarian dermoid cyst by the fat suppressed images, the fat in the dermoid will be suppressed from cystic ovarian neoplasms and from tube ovarian abscesses, as I will mention later on. Then we came to the ovarian hyperstimulation syndrome or the theca lutein cysts. And these cysts this disease is uncommon and is usually developed in relation to elevated human chorionic gonadotrophin in blood. And these cysts the disease will be bilateral and there are many big cysts in both ovaries. The ovaries are enlarged and they contain sizable cysts, not similar to the normal ovary, which contains cysts of different sizes, as I have mentioned before. Then this is an example of the theca lutein cyst. Sorry, this is an example of ovarian hyperstimulation syndrome, and you can see some of the sizable cysts in the ovary by ultrasound. Theca lutein cysts are large cysts, hypoechoic on ultrasound. They do not show some vascularity on Doppler examination, and the CT will show the typical appearance of a simple cyst with no mural thickening or nodules or enhancement, as you can see here in this case of a patient with a hydatiform mole, which is one of the causes of elevation of human chorionic gonadotrophin in the blood. You see both ovaries are markedly enlarged. They contain a lot of cysts of sizable of large size, and you see the some ovarian tissue in between. Then this is the gestational trophoblastic disease, which results from abnormal proliferation of the trophoblastic tissue, and this will result in one form of these forms: the hydatiform mole, which may be complete or partial, the invasive mole, and the choriocarcinoma. In these patients, women above 40 and below the age of 20 years are at higher risk of developing this trophoblastic disease. And the clinical presentation will be in the form of enlargement of the uterus and the no menstruation, high levels of human chorionic gonadotrophin, hyperemesis, and hypertension, and both ovaries being overstimulated will show multiple sizable bilateral cystic lesions. And this is the story of the trophoblastic disease. Either it may present in the form of complete form or partial form or invasive mole or chorionic or choriocarcinoma. The complete form is the commonest one, and in the uterus there is no fetus, and the human chorionic gonadotrophin is markedly elevated, and this may progress either to an invasive mole or to a choriocarcinoma. In cases of invasive mode, there is distortion of the uterine zonal anatomy, and you see in intrauterine soft tissue masses invading the myometrium and may extend into the parametrium as well. In the partial form, there may be some components of a fetus with moderately elevated human chorionic gonadotrophins in blood. And this is the appearance of choriocarcinoma by ultrasound. This malignancy is considered very rare, and this is the incidence of this malignancy. And diagnosis is usually performed when you can elicit the abnormal, very high increase of the human chorionic gonadotropins in the blood. And this is the ultrasound. You see the uterus is occupied by this abnormal echogenic mass. By MRI, the uterus is markedly enlarged. There may be focal endometrial masses. You see these irregular masses, and the tumor is highly vascular. You can see signal void vessels, which are not evident in this case, and consequently there may be hemorrhage and necrosis. The high beta human chorionic gonadotropin, which is still rising or reaching a plateau in about 8 to 10 weeks following evacuation of a molar pregnancy, suggests the development of invasive or metastatic trophoblastic disease. And this is the appearance of choriocarcinoma by CT. The uterus is enlarged, the endometrial cavity is very irregular, and there are extensive hypervascularity of the lesion and in the parametrium as well. This is by MRI. This is the choriocarcinoma T1, T2 weighted image, and T1 post-contrast fat suppressed sagittal image in a patient with vaginal bleeding in the serum. Beta human chorionic gonadotropin is about 12,114 milli-unit per milliliter. Then you see the irregular mass within the uterine cavity. You see the invasion of the myometrium in the enhanced image. And many times you can detect calcium, and the calcium is detected better by CT scan, and you see there is a mass in the uterine cavity which contains calcium, and you can also appreciate the invasion of the myometrium. And choriocarcinoma is a rare malignancy and is diagnosed by the elevation of beta human chorionic gonadotropin in blood. It appears as a solid lesion with myometrial invasion, which may simulate endometrial carcinoma. And the lesion tends to invade the myometrium, and these are some of the appearances of choriocarcinoma. 50% arises from a non-molar pregnancy, 30% follows abortion, and 20% follow a normal pregnancy. And metastases from choriocarcinoma can affect most commonly the lung, then may affect the vagina and the pelvis, the liver, and the brain. Then this is a female patient, 33 years old, with vaginal bleeding, and the uterus is very big. The endometrial cavity is distended. There is a regular endometrial myometrial interface, and you see the ovaries are studded by multiple sizable cystic lesions. This is also a trophoblastic disease, or the uterus is enlarged, and you see some calcium within the uterine cavity. You see the mass, you see irregular endometrial myometrial interface. Then the polycystic ovary syndrome is a disease which may result from abnormal gonadotropin secretions resulting in chronic anovulation. It affects about 50 to 10% of women in the reproductive age, and 50% of the patient may be infertile. Then the polycystic ovary syndrome can be associated with the pelvic venous congestion syndrome, which I will mention later on. Then what is the story of polycystic ovary? Normally, in the childbearing period, there are 5 to 7 small follicles in each ovary. And at the start of the menstrual cycle, the follicles grow to reach the maturation and hatch an egg. One follicle, which is known as the leading follicle, will grow to reach about 2 centimeters and ovulate. then the remaining follicles will degenerate and the new follicles will appear. And in the normal conditions, the ovary contains or maintains a constant number of small follicles throughout the menstrual cycle. But in cases of polycystic ovary syndrome, the ovary contains 2 or 3 times the normal number of the follicles, and there is failure of selection of a leading follicle. Most of the follicles are in the range of the same size, and as a result, the follicles will escape degeneration and they persist in the ovary. New follicles will appear, the number of the follicles will increase. The follicles are hormonally active, they produce androgen, and this will result in manifestations of the virilization, such as excess body hair, acne, and baldness. Then, if you look for the patient, and you can see abnormal hair, you can see some of the acne nodules, and there is, of course, some changes in the menstrual cycle. Most of the women will have a period every 2 to 3 months. 20% will have no period at all, and 15% may have apparently regular cycles. In the ultrasound, you can see that the ovary is enlarged and it is studded by many cystic lesions that are almost of the same size. An increased risk of endometrial cancer in patients with polycystic ovary syndrome younger than 40 years is known in literature. Then the polycystic ovary syndrome is also known as, or known in this syndrome, which is called the Stein-Leventhal syndrome, which is a combination of amenorrhea, hirsutism, and obesity. In the imaging finding, you can see the ovaries are bilaterally enlarged, and there are abnormally high number of the follicles, and the follicles are found in the periphery of the ovary, with no dominant ovary, no dominant follicle in the C. The follicles are arranged along the peripheral part of the ovary, and they are almost of the same size. Then the stroma, or the tissue of the ovary itself in between the follicles, will appear sclerotic of low signal in the T1 and T2 weighted images, and also the capsule of the ovary is thick and sclerotic as well. Then this is the appearance of the polycystic ovary, and this is the appearance of the normal ovary. And here you see the central stroma is dark, and the peripheral capsule is also dark. And this is how to differentiate between polycystic ovary and the normal multifollicular ovaries. In the normal ovaries, the cysts are fewer. They are of different sizes, in small and large and medium-sized follicles. Lack of stromal hypertrophy, the follicles are distributed throughout the ovary, and the follicles regress spontaneously. These follicles do not regress. Then we came to the benign ovarian neoplasms, and there are a lot of these lesions. We have the cystic teratoma, which represents a major part of these neoplasms, serous cystadenoma, mucinous cystadenoma, stromal tumors, and Brunner tumor. Starting first by the most common, which is the benign teratoma or mature cystic teratoma, and this is a very common or the most common ovarian neoplasm in patients under 45 years of age, and 70% of the tumor will be seen in the age below 19 years old. Then this is stroma ovarii is one of the teratomas that contains purely thyroid tissue, as I will mention later on. Ovarian cyst is diagnosed by the presence of three elements on imaging. Number one, fat. Number two, calcium. Number three, fluid. Calcium can be seen in the plain film, and you remember that fibroid will appear as a calcified mass in the female pelvis, but the calcium in the dermoid will appear like a tooth or something like this in the pelvis. Then you suspect that you are dealing with an ovarian dermoid cyst. But on ultrasound, CT or MRI, you will see the three elements. You see fat, and you see calcium, and you see the fluid as well. And this is an ovarian cyst, dermoid ovarian cyst. You see fat, which is more dark than fluid, and you see some other tissues within the dermoid cyst. And if you look carefully, you can see foci of calcium as well. On MRI, the the fat will appear bright in the T1 weighted images and somewhat also bright in the T2 weighted images, but in the fat suppressed images, the fat will be dark. And this image is very important to discriminate between hemorrhagic ovarian cyst or ovarian endometrioma and ovarian dermoid cyst. Then if you have the CT scan and you see the three components, the calcium and the fat, this very dark rim, and the fluid. And you know that these lesions are usually unilateral, but 10% of the ovarian dermoids are bilateral. And many times they are unilocular, but sometimes they are multilocular with internal septations. And this is the case of bilateral ovarian dermoid cysts. And you see, this is the left one and this is the right one. In the coronal image, it is easy to identify the calcium component and the fat. And also here you can see the calcium component and the fat as well. And this is MRI T1 weighted image and T2 weighted image and T1 fat suppressed image. You see a brightness of the fat in the T1 and T2, but there is suppression of the fat in the fat suppressed image diagnostic of the fat content. And this is an ovarian dermoid cyst, which is seen on the right side containing the calcium component and the fat component. Most of the dermoid cysts are asymptomatic and they tend to grow slowly, but they may rupture, they may lead to ovarian torsion, they may undergo malignant degeneration sometimes. And this is an example of an ovarian dermoid cyst containing the three elements, the fluid and the fat and the calcium as well. In the ovarian dermoid cyst should be differentiated from hemorrhagic ovarian cyst by the fat suppression. The hemorrhagic cyst will not suppressed in the fat suppressed images. It should be also differentiated from ovarian liposarcoma, which is very rare, or immature teratoma, which is considered extremely rare. Then this is T1 weighted image, T2 weighted image, and T1 fat suppressed image. On the T1, the fat is bright and is somewhat bright in the T2, but it is suppressed in the fat suppressed images. Then there are two types of ovarian cystadenoma, the serous and the mucinous cystadenoma. And 40% of benign ovarian tumors are of this cystadenoma. And after menopause, they account for up to 80% of the benign ovarian neoplasms, while they represent 40% in the reproductive age. And the incidence of serous cystadenoma bilaterally is about 20%, while the mucinous cystadenoma bilaterally is about 2%. Then serous cystadenoma is characterized by a huge unilocular cyst. And you see very big cyst, which is not discriminated from the simple ovarian cyst. It has the most of the criteria of the simple ovarian cyst, and many times you can diagnose this as huge simple ovarian cyst. But I feel that if you see a very big lesion which is unilocular, occupying most of the abdominal cavity, you may suspect the possibility of serous cystadenoma rather than simple ovarian cyst. And this is a good example of a female 17 years old with a big cyst occupying most of the abdominal cavity. The cyst is unilocular and fulfilling most of the criteria of the typical simple ovarian cyst. This is a serous cystadenoma of the ovary, sizable cyst with paper thin wall, clear water content, no internal septations. The cystadenoma, the mucinous cystadenoma, is characteristically multilocular, and this cyst is also of the large size. It can be small or can be large, but the cyst to be differentiated from serous cystadenoma, this cyst contains internal septations and may sometimes contain calcific foci, but if you see mural nodules or masses, and this will turn this cystadenoma into the malignant component, which is a mucinous cystadenocarcinoma. Then you remember that the mucinous benign ovarian cystadenoma is a sizable lesion, is a cystic lesion containing internal septations with no evidence of mural nodules or masses. And this is a big cystic lesion in the abdomen showing some internal septations diagnostic of mucinous cystadenoma. And by MRI, the lesion will contain fluid. The fluid will appear dark in the T1, bright in the T2 weighted image. You can see the septations in the T2 weighted image. Of course, in the fat suppressed images, you will not see any appreciable changes compared to the T1 weighted images. And this is a mucinous ovarian cystadenoma showing the classic criteria. The cyst is big, there are multiple internal septations, and one of the criteria of mucinous cystadenoma by MRI is that you may see some difference of signal between the cyst components of the lesion. Like this here, you see this cyst is somewhat bright compared to the adjacent one. And this is, of course, due to the difference in the contents of this very big tumor. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.